Thank you, Dan. So it's my pleasure, and I want to thank the organizer giving me this talk, this task. It will be a difficult task in 15 minutes, so I decided to solve the question, just asking the question for early gastric cancer, because it's clear that for advanced gastric cancer there will be less discussion than for early gastric cancer. If we look at the questions, we have to look at the prognosis of the gastric and esophageal cancer, the efficacy of adjuvant treatment, the neoadjuvant and perioperative treatment, and we will try to do some kind of synthesis. If we look at the prognosis of stage 2 gastric cancer, you can see that in the 6th classification, there was a prognosis which was rather poor with, rather good with 60% alive at 10 years. But in the 7th, no, it's a reverse, sorry. In the 7th classification, the prognosis is rather good if you inverse the classification, because 60% of the patients are alive, but 40% died. And the difference with 6th classification, in which only 44% of the patients are alive at 10 years, is the definition of T2 tumor. In the 6th classification, it concerns tumor invading the muscularis mucosae and submucosa, and in the 7th classification, it's just submucosa. So the question here is, what is the benefit of adjuvant and neoadjuvant treatment in the early gastric cancer? What does international literature tell us about this efficacy? I will first look at adjuvant treatment. And we run a very large meta-analysis using individual data, and this is the only one. It was a very good and nice collaboration between Asia and the rest of the world, and it has been published in JAMA 3 years ago. You can see that in this meta-analysis, near 5,000 data from individual patients has been analyzed. And if we check the stage of the patients, you can see that 47% of the patients included in the meta-analysis were T1 and T2, and 64% were stage 2. So that means that the result of this meta-analysis concern for 2/3 of the patients stage 2. The surgical procedure was D2 in 74%, but there was a big difference between Asia and the rest of the world. We can understand why. The result of the meta-analysis can be summarized here. In red, you have the overall survival. In blue, the disease-free survival. And you have the surgery-only arm in a dotted line, and the continuous line is surgery plus chemotherapy. You can see that there is a constant advantage, which is continuing across time. And if we look at the overall 5-year survival with chemotherapy after surgery, it was reported 59% versus 52%. That means in this large and huge meta-analysis, a 7% benefit. So from this analysis, it was clear that there was a benefit. The hazard ratio was 0.81. It was significant, and heterogeneity test was negative. So I think that the conclusion of the gastric meta-analysis is very firm, and we have done with Mark Boy's subgroup analysis looking at prognostic factors in this study, and you can see that older age, PS2, higher stage are prognostic factors. But also the treatment effect seems a little better in higher stage. However, there are two recent positive studies coming from Asia. I will go very fast because Dr. No gave us such a good lecture. As ACT compare S1 after surgery to surgery alone, and the result was very clear. There was an advantage for the S1 group, and if you look at the subgroup, there was also a good advantage for the stage 2 and T2 tumor with a hazard ratio of 0.6. We just heard the very nice communication from Professor No, so I will go very fast, just telling you that in the subgroup of patients with stage 2, the benefit was clear. So the efficacy of adjuvant chemotherapy is clear. It increases survival, but only for 5 to 10% of absolute benefit. And it decreased the relative risk of death by approximately 20%. The efficacy is observed for early stage cancer, but also for higher stage, and it's probably higher for higher stage. In the meta-analysis, it was surprising that there was no benefit for combined treatment versus 5-FU or oral 5-FU alone. And it was very strange. And even when you look at the result of the classic trial versus the ACT trial, there is a difference in favor of Xelox, adjuvant Xelox, but it's not so wide compared to S1. So really, we have a question: do we need polychemotherapy as adjuvant treatment, or do we need only oral 5-FU? This is a key question. And in Europe, at least, I believe that monotherapy is still a valid option as adjuvant treatment. But the problem, and it has been raised a few years ago with Arno Roth very nicely, is if you consider the whole population of patients treated by surgical resection, in the real life, approximately 30 to 50% of the patients will never have the chance to receive chemotherapy because all these reasons. And only 50 to 70% will receive an active adjuvant treatment. That means that if the patient had any complication after surgery, then we are not sure that we will be able to give him an adequate treatment, and this will be the case for huge tumor. So the objective of pre-op chemotherapy was to offer a treatment to a larger number of patients, to downstage the gastric tumor, to facilitate the surgery, to decrease the risk of recurrence and increase overall survival, and also to offer a better chance of a better tolerance and more efficient complementary treatment compared to adjuvant treatment. So we have 3 European randomized trials comparing surgery alone with chemotherapy before surgery and followed by chemotherapy for the NICE MAGIC trial and the French trial. The UATC trial just used pre-op chemotherapy and was underpowered. You can see that the regimen was not very different. In ECF was combination of epirubicin, cisplatin, and 5-FU, and the 5-FU platinum was a regimen used in France, and the duration of the pre-op chemotherapy was approximately 2 months. The result of MAGIC trial has been presented earlier. So just I want to focus. There was a 13% absolute difference at 5 years, and the hazard ratio was 0.75. In the French trial, the difference of overall survival was plus 14% in absolute benefit, as absolute benefit, and the hazard ratio was 0.69. And you can see that 5-year survival was quite the same between the MAGIC and the French trial. A meta-analysis recently reported, putting all the 3 trials in consideration, also reported an advantage in disease-free and event-free survival. So neoadjuvant chemotherapy improved event-free survival in this meta-analysis and confirmed the individual trials. There was also an interesting result in at least 2 of the trials. which report a higher rate of L0 resection in the French trial, plus 13%, and in the URTC trial, plus 15%, which unfortunately does not translate into overall survival, and don't understand why, because when you see the nice data coming from Munich on the survival after L0 resection compared to L1, L2 resection, it's clear that any treatment which will improve the L0 resection rate will be suitable for these patients. So my conclusion is that neoadjuvant chemotherapy is feasible and safe, and 90% of the patients are able to receive it. A significant downstaging are observed in most of the study. It does not increase the operative mortality and morbidity as will do chemoradiation therapy in some study. And there is no variation of treatment effect according to the tumor site. So EG junction has the same benefit as gastric, strictly gastric cancer. And it significantly improves survival in the two largest trials using chemotherapy. And it's indicated in stage 2 as well as in stage 3, because in the multivariate analysis there was no difference in the two stages. So if we look at the panorama of the adjuvant treatment in the world, and with Eric Van Kutsen, we asked to recognize after our expert meetings that there are a lot of different options. In the US, they are still giving in some center adjuvant post-op radiochemotherapy. In Europe, we are more around perioperative chemotherapy for stage 2 and 3. But it's clinical stage 2 and 3. This is one of the drawbacks of this strategy. And in Italy, they are still using more adjuvant chemotherapy. And in Asia, as you just heard, they are very concerned with adjuvant chemotherapy, probably because they have so good result with their D2 surgery. So if we look at the different parameters and the advantage of neoadjuvant versus adjuvant, you can see that performance status and nutritional status may be poorer in patients in adjuvant, because after surgery, many patients do poorly. The percentage of patients who may receive the treatment is lower in adjuvant than in neoadjuvant. The delay from the diagnostic to chemotherapy is longer in the adjuvant than in neoadjuvant. There are very few progression before surgery reported, but the surgeon opinion is always more favorable to operate on the patient rather than to wait 2 or 3 months before doing surgery. We have to convince them that it's not the good way and the right way to do and to manage the patients. For the patients, I don't know. For the overall survival, it's clear that we have advantage in the two strategy, and the L0 resection rate may be improved by a neoadjuvant approach. So my conclusion is the same as the St. Gallen expert consensus, which reports that for locally advanced gastric cancer, over T3 and plus, the preferred treatment modality was pre- and post-operative chemotherapy. And the majority of panel would also treat T2 and plus or even T2 and 0 tumor with a similar approach, because the pre-therapeutic staging was considered unreliable. So it's very important to consider this statement. And that's the question as, have we to give adjuvant or neoadjuvant in early stage gastric cancer? I clearly answer yes, if it's feasible, but I have to underline that we have to learn a lot from our colleagues from Asia, and because they have performed excellent adjuvant trial. And I want to congratulate Professor No, who is the president of the International Gastric Cancer Association, and who gave us such good lecture before me. Thank you.